very sick. Ejection from a vehicle is always something really serious. Any pedestrian struck by a car or struck by a motorcycle, or any bicyclist struck by a car, I really worry about those. Motorcycles freak me out. Anyone that gets hurt in a motorcycle, it's usually pretty bad. There's no protection from the world, so I take motorcycles really seriously, um, especially if they weren't wearing a helmet. Highway speeds, so anything that happened going 60 miles an hour, 100 kilometers an hour. Rollover if the car rolled. Any intrusion into the passenger compartment, like I said, any like indication that something came into the car and could have impacted the patient, that worries me. If the patient had to be extricated from the car by other people, so they could not get themselves out, someone had to help them get out. That always worries me. If the patient lost consciousness during the accident, I worry about that. If there was starring of the windshield, which our paramedics will sometimes tell us that they saw. Airbags, I don't know about this. We always ask, but there's some old cars that the airbags don't work. Sometimes they just don't go off. So I don't really take airbags super seriously. Maybe it tells me that the car was more significantly impacted, but they also do a good job of protecting people. So I don't know about airbags, but I do ask. For falls, all I care about is the height. That is all I care about. So I want to know, was it over 20 feet or under 20 feet? So I used to live in New York City, so I would ask what floor, what story, and usually the paramedics would tell me like this person had jumped from the 20th floor, 30th floor, 10th floor, second floor. I really want to know those things because that helps me. That's the only thing pretty much that I care about in a fall. And then for falls, 20 feet is your cutoff for severe. So 20 feet. So maybe, what is that in meters? Sorry, I really should put this in meters. Maybe 6 meters or more, 6 meters. Assaults. In general, hard objects tend to do more damage than fists, right? So sometimes I'll see patients who are assaulted with a baseball bat. I worry about that. Those tend to cause a lot of damage. Um, Fists, not quite so much. They can't quite do as much. If the patient was kicked while they're on the ground, I tend to take that pretty seriously. They can be pretty damaging. And then number of assailants, multiple assailants is obviously more concerning than just one. And then if the patient lost consciousness during the assault. For penetrating trauma, this is one of our places in the US where you can buy a gun, so that's great. We have this bullet rule that we use. So the number of holes that you find on the patient and the number of bullets that you see in imaging, those should be even when you add them up, right? So if you were shot by one bullet and there's one entry and one exit, that's good. You're done. But if you have a patient who comes in and they've been shot and they have, for example, 3 bullet holes, and then you do imaging and you can't find a bullet, that's concerning, right? Because that's one entry, one exit, and one entry, and then where's the exit? So what you need to do in that setting is you need to do imaging to try to find that bullet, and you need to do an exam to try to find the hole. So basically, when people come in with bullet wounds, we look really closely in the axilla and in the groin because those are places that bullet holes tend to hide, but really need to undress the patient and look everywhere to see the extent of the injuries. And then I also care about the type of gun. So rifles tend to be really high velocity and do a lot of damage, more so than pistols. Shotguns are low velocity, but because of the way that the shrapnel kind of spreads throughout the body and there's multiple foreign bodies, they tend to cause more damage than pistols, even though they're low velocity. And then blades wise, I tend to try to ask about the length of the blade and the location where the patient was stabbed. And those are kind of the things that I care about. This is an example of a patient I took care of who was shot by a shotgun. So you can kind of see the way that multiple pieces spread throughout the lung and cause pretty extensive pulmonary contusions there. So even though shotguns are like lower velocity, they really can cause significant damage. So I tend to take those pretty seriously. Okay, so you guys know this. This is just going to be a really quick review, but what do we do on our primary survey? So this is what I do the second the patient rolls in. So airway. And while I'm doing this, my nurses, my techs are putting the patient on the monitor. These are really rapid assessments. This is not like an extensive thing. This is a yes, no question for me. So for airway, is the patient breathing? Is the airway patent or no? So my first step is usually to try to get the patient to vocalize. And if they speak or scream, airway's patent, let's move on. For breathing wise, I listen for bilateral breath sounds. If they're roughly equal, we move on. I don't care if there's crackles. I don't care about like wheezes. I just care, are they bilateral? Then I move on. And if they're not bilateral, stop, think about a pneumothorax. Vital signs, usually at this point, the patient's on the monitor, so I can look at the pulse and the blood pressure. I don't like in the moment calculate a shock index, but I'm looking for signs of shock, right? I'm looking for tachycardia, I'm looking for hypotension, I'm looking for bradycardia. As an early sign of hemorrhagic shock, and we'll talk about this later, I'm looking for a narrow pulse pressure. Um, and then if I'm worried about shock and the story is consistent with trauma, I'll start blood here. For disability, calculated GCS, exposure, get the patient completely undressed and do an exam for external signs of trauma. And then this starts our secondary survey. And then if we have enough hands, we start a fast at this point. Secondary survey, again, we won't rush this too much. You guys know this, but the things that I want you to know are the red flags, okay? Any imaging can be done here and is adjuncts to the primary and secondary survey to help us answer clinical questions, right? But it shouldn't delay our management. Okay, make sure you roll the patient and look at their back as well. Okay, so any of these signs should give you a high index of suspicion for intra-abdominal or intrapelvic injury. So these should warrant advanced imaging or XLAP, kind of depending on the patient's stability. So early signs, positive fast, hemodynamic instability, pelvic instability, blood at the urethra or hematuria, narrow pulse pressure. Late signs, these are often talked about in textbooks, but the honest truth is that these are going to happen quite late. So if you're seeing these, you need to be really worried about that patient because we're already behind the ball. So bruising on exam, distended or rigid abdomen, okay? Um, we have a way to look at the bedside inside the abdomen for small amounts of blood, the FAST exam, right? Do it, master it, love it. Okay, so this is a super quick review of the EFAST exam. You guys know this. And we'll go over it again when we see you in September. But basically, right upper quadrant, left upper quadrant, suprapubic, and both lungs, okay? That's what we look for. And then, especially if it's penetrating the heart as well. And we're looking for any free blood, okay? We're looking free blood, pneumothorax, and hemoperitoneum, okay? The FAST has become standard of care for acutely injured trauma patients, so we should be doing it. We'll look at other signs and see if those have good sensitivity and specificity to tell us how injured the patient is. This is a pediatric study, so I know that like is a little bit less applicable to your practice, but because it's trauma, this should be fairly applicable to adults as well. So they looked at the sensitivity and specificity of the seatbelt sign, and it didn't have great test characteristics. So it had an okay, so this is for predicting abdominal injury. So it had an okay sensitivity, or sorry, okay specificity at 85%, but the sensitivity was really low at 25%. So it's not sensitive. So overall for me, the seatbelt sign is a red flag, right? If I see a seatbelt sign on exam, I think, okay, this is probably a fairly high mechanism, and I'm a little more worried about the patient, but I'm never going to use the absence of a seatbelt sign to make me think that the patient's okay. Okay, we do have some things with better sensitivity. So this is a really cool study. It's a retrospective study of a ton of trauma patients, 18,000 patients. who presented trauma patients who presented with systolic blood pressure over 90 on their initial presentation, and they looked at predictors of abdominal hemorrhage, and they found that narrow pulse pressure in the ER was found to be an independent predictor of abdominal hemorrhage. So that's awesome. That's really cool. We can use a narrow pulse pressure to predict abdominal hemorrhage. So if my patient comes in and they have a blood pressure of 100 over 80, for example, I'm going to be a little more concerned about that patient than if their blood pressure is 110 over 80, right? Okay. And we have another awesome bedside tool that is standard of care, right? The FAST exam. So this data is from a meta-analysis with a sum total of 12,000 patients. So a ton of patients, and they compared bedside ultrasound to either CT, diagnostic peritoneal lavage, XLAP, autopsy, or patient's clinical course. FAST had a really high specificity, so 96%. That's awesome. Sensitivity was slightly lower, so that means that a negative FAST does not actually, we can't use a negative FAST to rule out intra-abdominal injury. Okay? Okay, so can we use FAST as a rule-in test? Absolutely. Yes, please. A positive FAST in a patient who's hemodynamically unstable should be our indication to proceed to laparotomy, right? In many institutions, surgeons may want CT imaging to inform their surgical planning. And if this is the case at your institution, make sure that the resultant delay to definitive management is minimized as much as possible. So don't like order the CT and then walk away. This patient needs to go to CT now if we're going to get a CAT scan. And then make sure to resuscitate the patient aggressively before getting a CAT scan, okay? Okay, so can we use FAST as a rule out test? Not quite, not so fast, right? So there's a couple limitations to the FAST exam. One, retroperitoneal hemorrhage won't be seen. We can miss clotted blood. We can miss blood that's within the capsule of an organ, right? So if blood is contained within the liver capsule, for example, we could miss that on our FAST exam. But there are a couple things that we can do to increase our sensitivity. So we can do serial exams, right? We use this sometimes in children, for example. So if we want to avoid doing a CAT scan, for example, for some reason, or the patient doesn't meet criteria to get a CAT scan, then we could potentially consider doing serial FAST exams to evaluate their any concern for intra-abdominal hemorrhage. Okay. Other things we can do is practice a lot, right? As we gain experience with the FAST exam, we get better at it, just like any ultrasound study, and our sensitivity should increase. We also need to make sure that our FAST exams are thorough, right? They need to include the liver tip, the dome of the spleen, inferior pole of both kidneys, and the whole peritoneum from iliac vessel to iliac vessel, right? So even though we're going for speed, we also need to make sure that they're thorough and don't miss small amounts of intra-abdominal blood, okay? Okay, so this is some topics we're going to talk about as far as management. So we're going to talk about treatment priorities for the ER doc, right? We're going to talk about minimizing ongoing bleeding. We're going to talk about resuscitation, and we're going to talk about facilitating definitive management. So if you have suspicion for a pelvic ring fracture, it's recommended to place a pelvic binder. This is a practice, honestly, without an abundance of evidence, but the thought is that if the pelvic ring is broken, the potential space expands. So the potential space that can contain blood is now larger because the ring is broken. So the idea is that replicating the intact pelvic ring with the binder reduces that potential space back down to what it should be, and then decreases the amount of blood that the patient can lose into the pelvis. Um, we often do this a little wrong, so I just wanted to put some images on the screen to make sure that we're placing pelvic binders correctly. So they should be placed at the greater trochanter, right, which is lower than most people think. So people think they should be placed at the ASIS, but that's too high. We need to place them at the greater trochanter so that we effectively bring that pelvic ring back together. Okay, so what about TXA? So this is kind of the major TXA trial. It was a pretty groundbreaking study released in 2013, and it forms the basis of our use of TXA in trauma. So this was a massive RCT, so 20,000 adult trauma patients who presented within 8 hours of injury, and they were randomized to receive TXA or placebo. So what did we find? So this demonstrated an all-cause mortality benefit at 28 days, and mortality was significantly decreased by TXA versus the placebo group, with a relative risk of 0.91 and a confidence interval that did not cross zero. So TXA significantly reduced mortality at 28 days. From the same study, so they looked at patients who received TXA within 3 hours of injury and found that treatment after 3 hours actually increased the risk of death due to bleeding. So really unclear why we found that. It doesn't make a ton of sense, but because of that finding, we only recommend TXA in the first 3 hours after injury. So within 3 hours, TXA has a mortality benefit in trauma. That's awesome. Okay, so here's my conclusion in practice for TXA. So within 3 hours, yes, I absolutely give TXA, and then over 3 hours, I won't give it. And the protocol is 1 gram over 10 minutes, and then the bolus, and then the infusion is 1 gram over 8 hours, and you can place that in 50 mils of normal saline. Okay, let me get a drink of water. So, Reboa, there has been ongoing debate about this for probably the past 20 or 10 years. So Reboa is resuscitative endovascular balloon occlusion of the aorta. Reboa, okay? Um, Basically, there's been proponents of this and there's been adversaries of this for quite a while, and not a ton of data until recently. So what is Reboa? This is a quick diagram. So basically, Reboa is inserted through the femoral artery, and it's a balloon that goes up into the aorta to completely occlude blood flow distally. So it's kind of like an internal tourniquet, right? So there's two places that it can be placed. One is called zone 1, and that's anywhere from the descending aortic arch all the way down to the celiac trunk. So that is supposed to be for abdominal bleeding. So if a patient, for example, has a liver laceration, zone 1 placement is recommended. And then the other place that's recommended is zone 3, so distal to the renal arteries, but above the iliac bifurcation. Okay. So zone 2 is anything between those two and is from the celiac trunk to the renal arteries. And placement in zone 2 has never been recommended because of the concern for occluding those branches. So where do we stand on the data for Reboa, right? So the studies looked at both zone 1 and zone 3 together. Usually most studies had the clinician treating the patient decide which one they wanted to do. Okay, so this was a huge trial that came out fairly recently in 2023 examining Reboa. Okay, so this was a multi-center RCT from the UK, 16 major trauma centers, and it looked at Reboa versus standard of care for patients with confirmed or suspecting life-threatening torso hemorrhage. Okay, Bayesian model, which basically means that they try to estimate the amount of impact. Okay, so only 89 patients, okay? But they interestingly found that Reboa use was associated with an increased all-cause mortality at 90 days. And the trial was actually stopped prematurely due to evidence of harm. So that's pretty crazy. We thought that Reboa was helpful, but then the study came out and actually said, whoa, we think this is associated with increased mortality. So the authors hypothesized that the increased mortality was due to longer time to definitive hemorrhage control procedure in the Reboa group versus the standard of care group. And they looked into that, and that delay was about 19 minutes. So patients that got this balloon placed by ER doctors had a delay of 19 minutes to their definitive hemorrhage control surgery and an associated increased mortality. So there's some slight issues with the study. The Reboa group may have been a bit sicker at baseline when we look at the presenting systolic blood pressure alone. The authors state that they did adjust for this and there was little effect on the results, but still. And then additionally, the odds ratio for mortality at 90 days does cross 1. So unclear if it's actually statistically significant, but there is significant skew towards higher mortality in the Reboa group. So that's why the authors state that it may increase mortality. So there's a small chance that that is actually an error, right? A research error. But this high quality study used suggests that there's evidence of harm, likely due to delaying time to definitive management. So using the Bayesian model, they estimate that Reboa was associated with an 87% increased odds of death. Okay. So the bottom line, should we be using Reboa in trauma with concern for abdominal or pelvic hemorrhage? For now, there's no current strong evidence to support Reboa insertion by ER doctors in a system where it delays time to OR. Okay. However, this study was done in one specific system, right? This was in the UK. They don't see a ton of penetrating trauma. They're a high performing system. They have lower times from injury to to hospital. So that's a very unique system and it may not apply to other settings. They additionally don't see a ton of penetrating trauma. So there's a possibility that the result, if this study was repeated in a different system, there's a possibility that the result may be different. But we don't know this yet. So watch this space, stay tuned for further studies, but for now, no evidence to support Reboa, especially in a system where it delays time to OR, right? But there's some systems where Reboa is inserted in the OR while the patient is going and undergoing an XLAP. That may be helpful, right? So we still don't know. Okay, so quickly review the trauma triad of death, right? So this highlights the vicious cycle of factors that contribute to death and trauma. So while we as ER doctors can't take patients to the OR and control their bleedings, we have a huge role to play in resuscitating patients to combat these processes and hopefully improve patient survival after major trauma. Okay, so we can combat the coagulopathy by transfusing balanced blood products. We can combat the metabolic acidosis by resuscitation. We can combat the hypothermia by transfusing warm blood and keeping the patient warm. Okay. We'll go into each of these different methods that have evidence and talk about how to resuscitate trauma patients effectively. Okay, so when replacing blood, make sure it's like a good meal, right? It should be balanced, warm, and fast, okay? Rapid infusers like the one shown, this is called the Belmont. This is what we use in the hospital I trained for residency. This can give a liter of blood per minute. So that is insanely fast, right? And it also warms the blood as well. So it's giving warm liter of blood per minute, which is pretty amazing to get the patient resuscitated. So that achieves two of those goals. And then we aim to make our blood transfusion balanced, right? So that's trying to get the blood that we give the patient similar to the blood that the patient's losing. And the idea is that we're avoiding coagulopathy from depletion of proteins and platelets that help form clots. So there's two ways to do this. The first method, which is employed by the US military, is to transfuse whole blood. Some centers have this option, but it's really not widespread, and much more commonly, centers in the US have separate blood products. So the other option, if you have separate blood products, is attempting to recreate the composition of human blood by giving plasma, platelets, and red blood cells in a 1:1:1 ratio. So we'll talk about each of those. There's actually no randomized evidence, so no super high quality evidence to support blood transfusion in balanced ratios. But at this point, it is expert consensus based on many observational studies that have been done in the military and civilian settings as well. So this is the Eastern Trauma Guidelines. In the US, we have the Western Trauma Guidelines and the Eastern Trauma Guidelines. They're mostly the same, but they differ in some silly ways. So we use both of them basically. Um, but basically, the Eastern Trauma Guidelines suggest early transfusion in a balanced ratio of 1 to 1 or 1 to 1.5. Okay. Um, and then, yeah. Okay. And then whole blood. Is there any high quality evidence for whole blood? Not quite. But we don't have sufficient evidence to say that one is better than the other at this time. But watch this space. We'll see what studies come out in the future. And it is the military. The military uses it. So it's been done for quite a while. We just don't necessarily know if it's better than balanced blood transfusion. Okay. Shout out to this trauma resuscitation team player, the hospital blanket warmer. So this is super important when trauma patients come in. When we get them totally undressed, especially if it's in the winter, they're going to get cold. So make sure that they're covered up to decrease the amount of heat that they're losing, okay? Remember that hypothermia is part of that trauma lethal triad. Okay, as far as vasopressor use, so it's a really controversial topic. So European guidelines recommend vasopressor use for for failure to respond to fluid resuscitation, while American guidelines, the East and the West, do not encourage vasopressor use in trauma. So we certainly don't want to be reaching for vasopressors when the patient actually needs blood. And there's no current evidence to support vasopressor use in trauma, but there may be a role in the future for adjunctive vasopressors added on to blood to support hemodynamics during the early phases of resuscitation. So watch this space. There may be ongoing trials and research that comes out to support vasopressor use. For now, no, but watch this space. Here's a really quick review slide. So things we talked about in this lecture were trauma is a huge window of opportunity to prevent morbidity and mortality among relatively young patients. We talked about some mechanism pearls to determine how severe the mechanism was and kind of inform our index of suspicion for severe injury. And then, we went over our primary exam, our secondary exam, and briefly went over our fast exam. And then we gave some pearls for management. We talked about balanced warm blood given fast. We talked about giving TXA. And then we talked about the importance of getting the patient to the OR early. Okay, so let's do some questions. Oops, sorry, let me redo that.
I have a question.
Yes, please.
Okay, how about calcium in trauma? Calcium.
One more time.
Okay, how about calcium medicine? Calcium medicine in trauma.
Can you ask one more time? Sorry, I'm having trouble hearing you.
Okay. How about we use calcium? Calcium.
Oh,
Yeah.
calcium. Yeah. Great question. Yeah, absolutely indicated, especially when we're giving a huge amount of blood. So you guys know this, but blood products contain citrate. Let me just type it out in the chat box so you have it too. Okay, so basically, absolutely. So calcium contains citrate, which is a chelator. So when we give blood products, we deplete the body's source of calcium. Calcium can lead to nerve conduction issues, hypotension. So we do recommend repleting calcium to support the patient's hemodynamics. And also can cause coagulopathy, inability to contract blood vessels. So super important to replace calcium. Sorry, let me restart the share. I accidentally stopped it. Okay, feel free to answer in the chat or in out loud. Dr. Kong, I love your sandy beach going on. That's great. Okay, B. Everyone's saying B. Okay, so I found this one kind of hard too, but it's actually A. So let me go back to the question and I'll let you guys read it one more time. Okay, so basically, we didn't talk about this too much, but when there's a pelvic fracture, we worry about injury to the arteries of the pelvis. So even though CT seems like the right answer, it's basically because the patient is unstable and has a positive FAST. So if you follow the algorithm, um, pelvic X-ray exam is positive and then FAST is negative. So they recommend angiography rather than CT. I found this a little interesting question, but I just wanted you guys to see this so that you know that that's the textbook answer is that we're supposed to go to angiography. In practice, quite honestly, this patient would probably go to CAT scan pretty much every time, but the textbook answer is angiography, which isn't available in all centers, but that's what they want you to answer. Okay, this one should be a little more straightforward. Yeah, popcorn, that's totally correct. It's going to be A. Okay. So this is a stable patient, right? Not tachycardic, normal blood pressure with a positive FAST. So if the patient was unstable, they should go to XLAP, but the patient is stable, right? So it is okay in this patient to go to CAT scan to better assess the extent of the injuries and the location of the injuries to facilitate surgical planning and to determine if the patient will need operating room or interventional radiology. Okay. So stable patient, positive FAST, it's okay to go to CAT scan first. Unstable patient, positive FAST. The textbook answer is that they should go to XLAP right away. Okay. I know this is a chest x-ray, but I wanted you guys to see it to make sure you'd seen it, okay? Yeah, awesome. Yeah, you guys are great. You guys know what this is. Diaphragm rupture, okay? more likely on the left side because the liver protects the diaphragm. The spleen doesn't do such a great job. It's a much smaller organ. Okay. So diaphragm rupture, that's the stomach that you can see in the left hemithorax. Okay, I'm going to push you guys a little bit. So the most common sign. So there's one that we're taught in the textbook, but what do we think is most common? So not necessarily every patient will have blood at the meatus, but it's going to be B actually. So I think this is mostly just because more commonly we're going to see um, gross hematuria. So we're not always going to see blood at the meatus, but there still can be a bladder injury. Okay. The next slide's just my sources. Okay. What questions does everyone have? Let me stop the share. How do I get out? You're asking for a Reboa, right? Yeah. So Reboa for a long time it was really debated and we were doing it despite there being evidence because we felt that it would be helpful. And then this huge study came out that actually showed evidence of harm. So for now, in most systems, we've kind of put a hold on the Reboa catheter and we're not doing it anymore because of this large study. Well, it's not actually that large. It's only 90 patients, but there's currently not evidence to support it. So I wouldn't recommend its use. Uh-huh. Also, I mean, even when we were doing it, it's not every trauma center that has it. It was only certain centers that had it. I mean, maybe it's hard to say, but maybe like 1 in 5 trauma hospitals had it. It was pretty much only academic centers that were doing it and only certain among those. So it's not like it was widespread. It was more of a um dependent on the preference of the trauma surgeons at different hospitals. Anyone have other questions? Awesome. Well, I'll let you guys go a little early today, but thank you. Hopefully that was helpful. I'll put my slides in the drive in case you want to look over the papers or anything. Bye, guys.